Hello and good afternoon. My name is Zagam and I am currently on my way to internal medicine residency in the USA. Today in this presentation I'm going to talk about Cilta-Cel. It is a BCMA CAR T cell product for treatment of multiple myeloma, and it last month it got approved for earlier lines of therapy. So first of all, there is currently no cure for multiple myeloma. So the goal of therapy is to stop disease progression for as long as we can. So we use multiple types of drugs for that, including immunomodulatory drugs, proteasome inhibitors, anti-CD38 antibodies, etc. So we start one regimen. As long as the disease stays progression free, we continue that. And when it progresses or relapses, we change the regimen. So it leads to a poor prognosis. The disease keeps developing resistance. So Cilta-Cel was already approved by FDA for four or more than four prior lines of therapy. So now it is approved for more than one line of therapy in lenalidomide refractory patients. So as I said earlier, it is a BCMA CAR T cell product. What is BCMA? So BCMA is beta cell maturation antigen. What's special about it is that it is only present on myeloma cells and plasma cells, and they are expressed fairly uniformly on just these cells. So it makes it an ideal target for treatment of myeloma. And another thing which we know is that cells don't lose BCMA completely, so that makes it good for against resistance. uh, so BCMA, as we can see in this diagram, is that it is involved in survival and maturation of beta cells. So overexpression of BCMA is what causes progression of myeloma. So that's the main reason it is a promising target for multiple myeloma. So this is a list of treatment options which target BCMA. First one is antibody drug conjugates, and then bispecific antigen constructs, and then CAR T cells. Teclistamab is an example of bispecific antibody construct. And the two CAR T cell products for multiple myeloma treatment which are already approved are Ida-cel and Cilta-cel. Ida-cel is also just got approved for earlier lines of therapy, but it was for more than two lines of therapy. So this diagram shows mechanism of action of BCMA targeting therapies. So the first one on the left side is antibody drug conjugates. So it attaches onto the BCMA on surface of myeloma cells. This complex then gets internalized into the cell, which causes cell death. And the bispecific antibody, it has two ends. So one end gets attached to the T cell and the other end gets attached to the BCMA on surface of myeloma cells. So this interaction activates the T cells, which causes cellular lysis. So the way a myeloma cell can develop resistance to these therapies is by uh, disguising as a normal cell or sprouting a lot of these BCMAs or receptors, so that it's more difficult to get attached onto these receptors. So that's when CAR T cell products come in. So as you can see, CAR T cell has already has an antigen which can attach directly onto the BCMA receptor. So how did it get this thing? So it is genetically engineered in a lab. So we add artificially produced genetic material by viral transduction into healthy T cells, and then it is infused. These are infused back into the patient. So healthy T cells are collected from the patient after immunodepletion, so that the the immune system does not reject the new CAR T cell product. So after immunodepletion, T cell products are collected. Uh, T cells are collected, and then a CAR T cell product is produced in the lab, which takes around 2 weeks or maybe more, and then CAR T cell product is infused back into the patient, which is just a 5-minute infusion. So out of 2 CAR T cell products which are approved for multiple myeloma, what's special about Cilta-Cel? So Cilta-Cel has 2 binding domains. It has one CD3 zeta signaling domain with a 4-1BB co-stimulatory domain. So it makes attachment to the myeloma cell stronger, and it improves the T cell activation and proliferation. So again, Cilta-Cel was already approved by FDA in Feb 2022 for 4 or more than 4 prior lines of therapy, and these lines of therapy have to include a proteasome inhibitor, immunomodulatory drug, and an anti-CD3 monoclonal antibody. And now it is approved, it just got approved on April 5th for earlier lines of therapy, which is at least 1 prior line of therapy in Lenalidomide refractory patients. So what are the trials that led to this approval? So Cilta-Cel was first developed in China in a study called Legend 2 in 2016. So it was a phase 1 study, single arm, and number of patients was 74, and the median follow-up period was 48 months. So they achieved an overall response rate of 88% with complete response rate of more than 73%. And the median duration of response in this was 23 months, and median progression-free survival was 18 months. So Cilta-Cel was then later produced in USA by Janssen, and the main study involved in that was CARTITUDE 1. It was a phase 1B and 2 study, and it was a single arm 97 patients study, and median follow-up was 28 months, and they actually achieved an overall response rate of 98% with 83% stringent complete response, and median duration of response was not reached, and so was median progression free survival not reached, and median overall survival was also not reached. It means a considerable amount of patients were still progression free at the end of the follow-up period. In terms of safety, 95% patients developed cytokine release syndrome, and neurotoxicity was in 21% patients. These are the toxicities which are specific to CAR T cell treatment. We will talk about these in later slides. So the confirmatory phase 2 study in follow-up to the original Legend study in China was CARTIFAN 1, which was done in 2019, and they achieved an overall response rate of 90%. So CARTITUDE 2 is a multi-cohort trial exploring earlier line of use of Cilta-Cel in earlier lines in multiple cohorts, and CARTITUDE 4 is what actually led to this approval we are discussing in this presentation. So it is a phase 3 study in patients with 1 to 3 prior lines of therapy, and the comparator arm were patients with pomalidomide, Velcade, Dex, or daratumumab, Pom Dex. And CARTITUDE 5 trial was started in 2021, which is still going on, and it compares Cilta-Cel versus Velcade, Revlimid, Dex in patients in which transplant is not intended, and it is for newly diagnosed patients. CARTITUDE 6 started in 2022 is also for newly diagnosed patients, but these are transplant eligible. So it compares two arms, one for Cilta-Cel and other one for transplant patients. And the CAR-T new trial is another trial started in 2023, and it assesses long-term safety of patients enrolled earlier in all these CARTITUDE trials. So what is CARTITUDE 4? This is the trial which led to this approval. This is the paper we will be discussing mainly in this presentation. So this is the study design. So total number of patients is 419, and these are the inclusion criteria for this study. So the age has to be more than 18 years old in patients with multiple myeloma, and it is for 1 to 3 prior lines of therapy, and patients have to be lenalidomide refractory and Eastern Oncology Cooperative Group performance score of less than 1, and the patients have not received any CAR-T or BCMA targeting therapy before. So the patients are stratified into two groups, and one for standard of care, which is Pom Velcade Dex or Dara Pom Dex, and the other one into the Cilta-Cel. So it had two arms. Standard of care arm had 211 patients, and Cilta-Cel arm had 209 patients. So in Cilta-Cel arm, so here if in apheresis, so T cells are collected, and then after lymphodepletion Cilta-Cel is infused, and then from day 1 to day 112 the data is collected for safety, efficacy, pharmacodynamics, and these things, and this data is collected every 28 days, and after this the patients are followed up. So what is the primary endpoint in this trial? So primary endpoint is progression-free survival. As I said earlier, the goal of our therapy in multiple myeloma is progression-free survival. And what are the secondary endpoints? It is efficacy, which includes complete response, overall response rate, and MRD negativity, which is minimal residual disease, and overall survival of the patients. And the other endpoints are safety and patient reported outcome. So what are the baseline demographics of patients in this study? So both arms have fairly similar patients. As we can see, most of the patients were stage 1 according to international staging system, and followed by stage 2 and stage 3 in both arms. and presence of plasmacytomas 21% versus 16%. And cytogenetic risk, similar stats in both arms. So all of the patients, obviously that was an inclusion criteria. All of the patients are lenalidomide refractory, and 23% in Cilta-Cel arm versus 21% in standard of care arm were daratumumab refractory, and 14.4 and 15.5 15.6 respectively were triple class refractory. So this graph shows progression-free survival in both arms. So as we can see, so 12-month progression-free survival was achieved in 76% in Cilta-Cel arm versus 49% in standard of care arm, and median progression-free survival was not reached in Cilta-Cel arm versus 11.8 months in standard of care arm. So standard of care performed as expected. So this table also shows progression-free survival in both arms, as we have discussed in the last slide. So overall response rate was 85% in Cilta-Cel arm versus 67% in standard of care, and 73% versus 22% of complete response in Cilta-Cel versus standard of care arm. And MRD negativity was achieved in 61% of the patients and versus 16% of the patients in standard of care arm. So this chart compares, so this is these are the survival curves for progression-free survival according to prior line of therapy. So one prior line of therapy has best progression-free survival, and after that 2 to 3 prior lines of therapy in Cilta-Cel, and then this green curve shows survival for progression-free survival for standard of care arm in one prior line of therapy versus 2 to 3 prior line of therapies in standard of care arms. So this table shows secondary endpoints. So overall response in Cilta-Cel arm was 84%, 84.6% versus 67.3% in standard of care arm, and 58% of stringent complete response was achieved in Cilta-Cel arm versus just 15% of stringent complete response in standard of care arm. So this graph shows the results we just discussed in the last slide. The overall response is 84% in Cilta-Cel arm versus 67% in standard of care arm, and 58.2% of complete response in Cilta-Cel arm versus 15.2% in standard of care arm. So this slide shows overall response rate and progression-free survival for as treated population in Cilta-Cel arm. So overall response rate is 99% with more than 86% of complete response and 72% MRD negativity achieved in as treated population. So MRD negativity is in MRD test we can detect one cell in a million normal cell, one abnormal cell in a million normal cells. So and 90% of at 12-month period 90% of the patients were progression free. So this slide shows MRD negativity in intention to treat versus as treated population in both arms. Cilta-Cel provided a significant improvement in response and greater MRD negativity versus standard of care arm. So this slide shows curves for progression-free survival in CARTITUDE 4 versus CARTITUDE 1. So CARTITUDE 4 shows better progression-free survival versus CARTITUDE 1, which means it has a better response in earlier lines of therapy than in later lines of therapy. So this slide shows treatment emergent adverse effects in both Cilta-Cel and standard of care arms. So hematological events like neutropenia, thrombocytopenia, anemia are considerable in both arms, and infection too. But cytokine release syndrome and neurotoxicity are the adverse effects which are specific to CAR T cell products. 76% of the patients actually developed cytokine release syndrome, and 20% did neurotoxicity in Cilta-Cel arm. So cytokine release syndrome is when we infuse CAR T cell product. This is the first adverse effect that can potentially happen. So T cells release cytokines. These are inflammatory molecules which produce flu-like symptoms like fever, weakness, pains, etc. And neurotoxicity or immune effector cell associated neurotoxicity syndrome. This happens because of inflammation. Blood brain barrier is compromised and it causes inflammation of the brain tissue. But these side effects are controllable. These are not long term, and these are controlled by immunomodulators like tocilizumab, cilta-cel, and anakinra. So hematological side effects are the most common in both arms. In Cilta-Cel arm 2, 85 to 90% patient developed neutropenia, which was grade 3 and 4, and but most high grade cytopenias were resolved by resolved to less than or equal to grade 2 by day 30, and grade 3 and 4 infections were similar between both arms. And secondary primary malignancies, these were less common in Cilta-Cel arm for 4.3% versus 6.7% in standard of care arm, and deaths due to side effects were in 10 patients in Cilta-Cel arm and 5 patients in standard of care arm. Out of these 10 patients, 7 were due to COVID-19. So 30 patients in the as treated population of Cilta-Cel had non-ICANS neurotoxicities like cranial nerve palsies and peripheral neuropathies. So there was lower incidence and severity of cytokine release syndrome, ICANS, MNTs, and some cytopenias in CARTITUDE 4 versus CARTITUDE 1, which means Cilta-Cel is better tolerated in prior lines of therapy than in later lines of therapy. And there were no fetal neurotoxicities in CAR T cell, and effective bridging therapy enables better control of tumor burden prior to CAR T cell infusion. So this slide shows causes of death in Cilta-Cel arm versus standard of care arm. So 14 patients in Cilta-Cel arm died due to progressive disease versus 30 patients in the standard of care arm, and 15 patients in the Cilta-Cel versus 11 patients died due to treatment emergent adverse effects. Discuss the limitations of this trial. One potential limitation is that two of the treatment regimens, which are daratumumab, carfilzomib, and dexamethasone, and isatuximab, carfilzomib, and dexamethasone, these were not approved at the time of initiation of trial, so these were not included in the standard of care arm. And another limitation is that the 7 deaths reported in Cilta-Cel arm are due to COVID-19, and these were after 4 months of Cilta-Cel infusion. So if we exclude those, that shows a even better safety profile for Cilta-Cel. So what are the conclusions? So the Cilta-Cel significantly prolonged progression-free survival versus standard of care arm in patients with lenalidomide refractory multiple myeloma with 1 to 3 prior lines of therapy, and that included patients with high-risk cytogenetics, soft tissue plasmacytomas, and stage 3 disease, and prior exposure to anti-CD38 antibody and proteasome inhibitors. Cilta-Cel significantly increased overall response rate versus standard of care arm, and overall response rate in Cilta-Cel as treated group was 99% versus 86% of complete response and 72% of minimal residual disease. CAR T specific adverse effects were manageable with appropriate supportive care, and there was lower incidence of and severity of cytokine release syndromes and other side effects in CARTITUDE 4 versus CARTITUDE 1, which suggests that it is better tolerated in earlier lines of therapy. So another point is that it improves progression-free survival but does not improve overall survival in patients with multiple myeloma. So understanding the mechanisms of drug resistance is the area of interest for future research, which is currently going on, and Median duration of progression-free survival in CARTITUDE-4 extended beyond the median duration of detectability in CAR T cells. So it was similar to observations in CARTITUDE-1. So the biggest question currently in multiple myeloma treatment is, can we find the cure to multiple myeloma? And we are very optimistic about that. Thank you.